ready.
Just like useless to even talk about, but I'm going to mention it in case you're not familiar. SBAR. I'm not going to have you hand these in, but you need to know how to hand over patients. So meaning one of the worst things that happens in outcomes for patients is inability to communicate from one area to the next. And there's all kinds of controversies about how certain areas don't communicate well with the next area and you miss things and then patient outcomes are diminished. When patients even transfer out of the hospital, get discharged, there is no communication that does well between hospital and outpatient. And then a lot of stuff gets missed and so things don't get followed through. So guess who gets readmitted? Patients. Because it's very hard for patients to understand all the stuff we try to teach them. It's probably the #1 admission to the hospitals here in town is diabetic. Uncontrolled diabetes. And all the other sundry, so cardiac failure, coronary artery disease, hypertension, all are a big lump with, and renal failure with diabetes. And unfortunately, some people choose not to be compliant, but not all of it's compliance. Some of it's the fact they cannot understand their very complex healthcare plan. There's a lot of things that have to be done. If I'm diabetic, there's so much stuff that has to be done for a diabetic, and most of them are on the wrong medicines. That's why it's so important for you when you're reviewing charts that you understand. This is what's important. SBAR allows you to organize your thoughts to make sure that like when you're handing over to the next shift, that you're giving them the right stuff. I am going to require, and I'm requesting that my other clinical instructors require that during each of the post conferences that randomly we will select one person to do a handover to the group. Because that's one of the biggest things we get is a problem from the hospitals. By the way, we send evaluations out to hospitals. How are our new grads doing? And we are really lucky because most of the ASNs are being hired readily. The hospitals are very happy to hire you, so that's because you have a good reputation. And we're counting on part of it being us teaching you the right things and part of it being you learning the right things and applying them. Okay, it takes us both. So the point is we want to maintain a good relationship with the hiring facilities because you want a job, right? You're just not going to school for fun? That's what I've been doing for 30 years. But the point is you kind of want a job in between there to pay for school, right? So the issue is they want us to communicate better. That's one of the things they're finding is a problem is there's not good communication. I always hear at the hospital, and I'm not picking on her because she's not here right now, but the ED did a new little thing where they didn't really have to talk to the actual nurse taking the patient. I don't like to hear handover. I don't want the charge nurse to take my handover information. So if they're going to transfer a patient into me, I want to be the person that hears the stuff because I have questions I want to ask. When I got patients back from the OR, those anesthesia people had very, very specific things they wanted to tell me. I had more things I wanted to know. And they said, well, read the chart. I said, no. You lived it for the last however many hours in surgery. I want to hear from you what happened. I don't have to have precise numbers, but I want to know, did they go hypotensive? How many times did they go hypotensive? Did you have to fluid bolus? Did you have to use drugs to improve their pressure? That's all really important for me as a post-surgical nurse.
And that's why a good OR nurse will stay until the anesthesiologist and the doc leaves, and you say, is there anything else I can tell you?
But you're a good one. I've never interacted with them, I guess.
Well, some are good.
I know. I'm just teasing. I'm just teasing. Because we've had several recently that have been hired directly to the OR. I always like people to get a little bit of experience someplace else before you go to specialty units. And I know you'll say critical care specialty, but not anymore. Critical care is not really. ED's a harder transition to go into as a new grad, just because it's a hodgepodge of patients. That's how I always looked at it. You know, I had students coming into the residency program at Vanderbilt, and they had 5 opportunities for units to go to, and one was the ED. And the issue is, do a year in one of the other critical care units and then go to the ED, because it just helps you to transition the material. The EDs are pretty rough, because you don't get to really learn much about anything. You got all this different stuff going on. You learn really well how to save patients' lives really quick, but you don't get able to see the continuum. And this is what the whole thing is. You got to be able to precisely give the information. SBAR allows that. So I expect for you to be able to do a handover. And I'm hoping that, again, that everybody will use that opportunity, because that's one of the things the hospitals are saying that we are weak in as graduates. And I'm not saying that they're not saying that about the BSNs too. I don't care what they say about them. I care what they say about our evaluations. Because I don't look at the BSN evaluations, I look at the ASN evaluations to know what we can do to improve, and I'm not talking to you negative about this, the product that we are delivering to the hospital. You're the product. You're an exceptional product. And we just want to make sure that you continue to be exceptional or even more exceptional. Okay? So SBAR okay? Any questions about that? And again, I'm not going to pick them up because I don't want any more paperwork to go through than I have to. I'm serious. But sometimes that helps you to be able to organize your thoughts. I'm already past that part. I don't have to have a piece of paper to organize my thoughts. And I know that when because I always went on rounds with the new grads, because that's the hardest thing is for them to get handover from an experienced nurse on nights or days and then figure out what am I going to do with this information. It's just like, as a new grad coming out of school, I don't care what unit you go to, it's going to be scary because you haven't had the practice yet. Okay, was it mine? I thought I didn't bring mine, I don't think, or I lost it, which is also possible. Very possible. Okay, Pamper. Is everybody familiar with this form? Okay. Again, it's just another way to look at that. And again, patient information goes through a series of demographics, and the assessments, what specifically did you see in your patient? Medications, what are they on? And again, there's going to be, most patients have 25, 30 drugs. The important part for you, and it's going to go back to the concept map, and I had a question saying that you're not experts at concept maps. I know some of you in second semester did that, but the LPNs have not dealt with our concept map concepts yet. So again, we're gonna work on that with you. That's not gonna be a problem. Your instructor will specifically, I think you're with Miss Metter, right? No, you're.
Yes.
Who's with Miss Metter? That's LPN. Okay. So they're going to need a little bit of extra help with concept maps just because that's not been a part of their last semester. Okay? So when we go back and look at the meds, I do not want to see a drug card. Whatever way you learn drugs is whatever way you do it. I don't care, but I don't want a drug card brought to me. I don't do drug cards. Okay? Again, I'm not a paper person. I don't want to see all your papers. You need to figure out a way that you can incorporate the knowledge before you finish. One thing that I always do, this is what we're going to do today when we go over to the medical center, is I got some time, I got about an hour I need to have you kill, and then I'm going to have you go to certain units. And when you go to the unit, you're going to divide up, and you're going to find a couple nurses, and not going to inflict yourselves on them and cause havoc, but you're going to ask them, what are the 10 most common drugs used in this unit? So each of you will pick 5. And then that's going to be important because you better know what those drugs are before you go to that unit. That's going to help you know what's the most common things they use here. Because I bet you haven't used a lot of Levothed in your practice yet. And I don't want a drug card on it. I know I woke up with neosynephrine on me in December because they didn't give me any fluid. Okay? So the point is, you need to know what the drugs are for. And you're going to be using a whole different set of drugs. You're going to be using some, there's insulin. There's a lot of patients getting insulin. And you should be very well versed with insulin by this part of your life. There's going to be a lot of metoprolol. The beta blockers are pretty happy, ACE inhibitors, and you're going to need to know them, and you're going to need to know how they work different for hypertension versus congestive heart failure versus MIs. So yeah, you're going to have about 6 weeks to figure that out. And each area we're going to talk about, well, why would I use it in this population? And it's not the same reason. I'm not using a ACE inhibitor to control blood pressure typically in my congestive heart failure patient. Whole different mechanism, and I'm not going to test completely cellular, partially cellular. Because you need to know why things work and why we get better outcomes. Why is this a drug of choice? Why should it be used in 90% of the patients for better outcomes? Why does it reduce morbidity and mortality by 90%? That's the kind of stuff you need to know. I don't care if you know percentages, but you need to know why should this patient be on this drug, and if they're not on it and they're in here with congestive heart failure, then is that something I should be bringing to the attention of someone? And I don't care, I don't expect you to talk to doctors right now. And that would be wonderful if we could have the relationship to where we could have, some doctors are going to love you as students. Some doctors are going to hate you as students. And you're going to see both types. There's this one little pulmonologist that brought all the little students in. He said, come on, let me teach you about the ventilator. And he'd go in there and he did it to a level that was understandable for them, and it was just, I about passed out. Because I haven't seen a lot of collegiality with the physicians and students and nurses in general. Let's just say nurses in general, students in particular. So the point is, I was pretty impressed. And so I said, I need to make sure that he's there every Tuesday and that I have students hovering, waiting for him, okay? And if they're with a different patient that doesn't have a ventilator, they need to go in there when he starts doing his little spew about ventilators, because that's going to help them to grasp the concept of ventilators. And I don't like to not be collegial with the team. You have to be interdisciplinary, but sometimes, you know, they gotta give a little bit too. It's not just nursing giving all the time. I'm kind of over that. I'm kind of assertive. Some people would say aggressive. And but I'm very advocate for nursing, because I know who saves patients' lives. And if they hadn't listened to nurses for years, so a lot of these patients wouldn't be here 20, 30 years later because the doctors didn't pick up. So under all this information, this is just pamper. I don't care about seeing the paper. It's however you assimilate your ability to hand over patients. You got to learn how to communicate. And I don't want an exhaustive coverage of everything about the patient's history, but we have to have some way to get the information. That's going to be really important. Ms. Stewart's back. She's now taken over.